Good morning. Today we'll have two short case discussion. One on tubercular cervical lymphadenitis and other on lymphadenopathy due to lymphoma. So the first case will be presented by Dr. Ishita Laha, who is a third-year junior resident at Ramakrishna Mission, Shivapur Vivekananda Institute of Medical Sciences. And second case will be Dr. RM Jyoti, who is exam-going candidate at MR Bangalore Hospital. And today, Professor Ujjwal Bhattacharya, who is a professor and head of surgery at National Medical College, will be the examiner today, and I will also be there. Ishita, you can share your screen and present the case.
Good morning, sir.
Good morning.
My screen is visible, I suppose.
Yes, it is visible.
Good morning, everyone. Myself, Dr. Ishita, presenting a case on cervical swelling. Mrs. X, a 42-year-old female health worker resident of Kolkata, attended the outdoor with a chief complaint of swelling over the right side of the neck for last 6 months and a creamy white discharge from the swelling for last 3 months. The patient was apparently well 3 years back when she was diagnosed with pulmonary TB and had subsequently taken anti-tubercular drugs for 6 months. Post course of this treatment, she was rendered cured. After that, she has been asymptomatic for 2 years and then again developed this swelling over the right side of the lower part of the neck. The swelling was initially of the size 2 into 2 centimeter in size, which was insidious in onset, gradually progressing in nature to attain the current size approximately 8 into 6 centimeter over 6 months. The swelling was not associated with any pain or rapid enlargement in size or high-grade fever. For last 3 months, she complains of a creamy white discharge with foul smell from the lower part of the swelling. The drainage was intermittent in nature and no history of diminution of size of the swelling on discharge. She also complained of associated occasional evening rise of temperature which subsided on oral medicines. Also associated with loss of appetite and weight loss and also easy fatigue after working her daily course. There was no history of neck pain, radiation exposure in the childhood, swelling elsewhere in the neck, any intervention in the neck, any non-healing ulcer in the oral cavity, dental caries, abdominal symptoms including ascites, pain, lump, and jaundice, and chest symptoms like hemoptysis, prolonged cough, or shortness of breath. Past history, the history of tuberculosis in the past, followed by 6 months on intake of 6 months of intake of short course chemotherapy, and no history of previous surgery, no history of any hospital admission. She is a non-vegetarian and she has no addiction history. Bowel, bladder, sleep are all normal. Appetite is decreased. No associated comorbidities like type 2 diabetes mellitus or hypertension, and no history of any allergy to known food or drug. There is no similar illness in any other member of the family. I summarize my history as a 42-year-old lady who attended the outdoor with a large swelling on the right side of the neck for last 6 months, associated with a creamy white discharge for last 3 months, and she has a past history of pulmonary TB for which she had received anti-tubercular drugs for 6 months and was declared cured, and also associated with evening rise of temperature with loss of appetite and weight. So shall I proceed?
So, what seems to be your provisional diagnosis?
The first diagnosis comes to be a cervical lymphadenopathy due to tuberculosis.
Not first. What is your provisional diagnosis? So, provisional diagnosis should be the only one diagnosis. What is that?
So, it is a tubercular lymphadenopathy complicated with sinus formation.
So,
it is just a summary of the history. I have I am yet to proceed for general examination and loco-regional examination.
Oh, this is summary of the history. Okay. Go on your clinical examination. Yes, right.
Okay.
Finish up the examination.
Okay. Thank you, sir. On general survey is essentially normal with a Karnofsky scale of 80 and pallor was present, and there was no generalized lymphadenopathy. Vital signs was a pulse 78 beats per minute in the right radial artery with a BP of 110/70 in millimeters of mercury, and respiratory rate of 15 per minute with a febrile. I have done the inspection and palpation together after explaining the patient what am I going to do, and in presence of clear daylight and in presence of a female chaperone. There is a solitary 8 × 6 centimeter globular swelling noted over the right lateral aspect of the neck, involving 2/3 of both the anterior and posterior triangle. Anteriorly, it extends up to 3 centimeter lateral to the thyroid cartilage and extends upward 1 centimeter below the lower border of thyroid cartilage. Posteriorly, it extends 3 centimeter anterior to the lateral border of the trapezius and downward up to 2 centimeter above the clavicle. It is non-tender. It has a smooth surface, well-defined margins with firm consistency and restricted mobility. Fluctuation and transillumination tests are negative. No expansile pulsation over the swelling, and overlying skin is fixed at the lower part. There is a sinus tract present in the lower aspect of the swelling with undermined edges with induration over the surrounding skin. There is a visible skin erosion with creamy white discharge. Carotid pulsation present at the normal position. No separate lymph nodes palpable on the same or opposite side. Examination of oral cavity, as in oral mucosa, tonsillar fossa, retromolar trigone are all normal. There is no presence of dental caries or non-healing ulcers in the oral cavity. Examination of salivary glands and temporomandibular joint and scalp, cervical spine are all normal, and examination of other lymph nodes in the body are not palpable. My systemic examination was essentially normal. I summarize it as a 42-year-old lady who attended the OPD with a large swelling on right side of the neck for last 6 months, associated with a creamy white discharge for last 3 months. She has a past history of pulmonary TB for which she had received ATT for 6 months and was declared cured. Also associated with evening rise of temperature with loss of appetite and weight. On examination, patient was anemic with a BMI of 21 kg per meter square. And there is a solitary 8 × 6 centimeter globular swelling noted on the right lateral aspect of the neck, involving 2/3 of both anterior and posterior triangle. Anteriorly, it extends up to 3 centimeter lateral to the thyroid cartilage and extends upward 1 centimeter below the lower border of thyroid cartilage. And posteriorly, it extends 3 centimeter anterior to the lateral border of trapezius and downwards up to 2 centimeter above the clavicle. The swelling is non-tender, smooth surface with well-defined margins and consistency, and there is a sinus tract present in the lower aspect of the swelling with undermined edges with induration over the surrounding skin, and there is a visible skin erosion with creamy white discharge. I provisionally diagnosed my case as a tubercular lymphadenoma, complicated with to a sinus formation in a 42-year-old lady with a past history of pulmonary TB. Thank you.
In your provisional diagnosis, I can see you have written tubercular lymphedema.
Yes,
That should be tubercular lymphadenitis, not lymphedema. In your provisional diagnosis, what you have written?
Okay.
Tubercular, complicated to a sinus formation in a 42-year-old lady with a history of pulmonary tuberculosis. Okay. So, what are your differential diagnosis in this case?
Yes, sir.
Differential diagnosis.
Sir, I am not being able to hear, sir. Can you please?
Any
Hello?
differential diagnosis?
Yes, sir. Differential, sir. It can be, sir, neoplastic in origin, but since
Next
she
is
has a
neoplastic. No, Ishita, try to understand. Don't jump to a uncommon diagnosis. This is a patient having a sinus with discharge. So it is unlikely that
sir, it can be, sir, branchial fistula, sir.
branchial fistula.
Sir, but it is uncommon.
With...
But it is uncommon in such age group. And sir, it can also be chronic pyogenic lymphadenitis, sir. Pyogenic lymphadenitis, sir.
Yes, that should be the second diagnosis.
And sir, also
what else?
Sir, also tubercular lymphadenitis due to due to Mycobacterium avium complex, sir.
You mean atypical microbacterial infection?
Atypical, yes, yes, sir.
Anything else? You said whitish discharge, creamy discharge.
Mm.
Any fungal infection can cause such
Sir,
discharge?
actinomycosis, sir. Cervical actinomycosis.
Yes.
Is it a fungal infection?
No, it is a bacterial. No, it is a bacterial infection.
So it's a bacterial. What bacteria causes actinomycosis?
Sir,
Which bacteria?
sir, nocardia, sir.
No.
Then what are the points in favor of your clinical diagnosis that this is a tubercular cervical lymphadenopathy?
Sir, from the history, sir, she complains of the, she has a past history of pulmonary TB with, and who has received treatment for ATT. So after seeing this swelling and sinus discharge, the first thing which comes in our mind is of cervical TB. And sir, next, sir, she also gives a history of evening rise of temperature with loss of appetite and weight, which also favors the diagnosis of TB. And sir, on examination, sir, it is a large swelling with, and the lymph nodes are matted, and it is a
Is
firm.
matted, multiple matted lymph nodes.
Yes,
You
multiple
say,
matted.
these are actually basically not a single cell, but multiple matted lymph nodes. Okay.
Yes, sir.
Involving which group of lymph nodes, which levels of lymph nodes in the neck?
Sir, involving 2 and 3, sir.
Only 2 and 3. Not
Sir, it is actually extending to the posterior triangle also. Sir, so in that.
What is basically the level 2 and
Sir,
where is this nodal swelling situated in your case?
Sir,
Basically, which one is the level 2?
The level 2 extends from below the ramus of mandible to the lower border of the hyoid bone. Anteriorly.
Yes, upper border of the thyroid cartilage. Okay. And
Yes.
where is this swelling present?
So this swelling is present, sir, from level 2, level 2 and level 3, and again means it is also taking a part of posterior triangle also, and it is like 1 centimeter below the margin of mandible and 2 centimeter above the clavicle. So it is.
What are the different levels of lymph nodes anatomically?
Sir, so we have, sir, 7 levels of lymph nodes, sir, cervical lymph nodes.
Yes. And what is level 2A and 2B?
Sir, 2A, 2 and 2B is medial and lateral, and that is divided by
medial and lateral.
Sir, that is demarcated by cranial part of no, sorry, spinal part of the spinal accessory nerve. Means cranial nerve.
Spinal accessory nerve. Okay. Okay. So there are okay. Now then how will you confirm your disease in this situation?
First of all,
your provisional diagnosis.
Yes, sir. Sir, I will like to go for, sir, chest X-ray, and sir, sputum culture for 3 days. If all those comes negative, and then I will try to associated with the ultrasound of the neck, and then when this will not corroborate.
So
then
what is the reason of doing ultrasonogram? With what intention you are going for an ultrasonogram of the neck?
Sir, any palpable, any lymph node which are not visible, any occult lymph node in the neck, and also, sir, any other lymph node. So any other occult lymph node in the leg. So that is we want to denote that, and associated with the other swelling also, we will be able to better see it if it has central necrosis, central caseous necrosis. And
Ishita,
yes, sir.
In this patient, in this presentation, she has no symptoms of pulmonary tuberculosis. So
Yes.
why do you jump to chest X-ray for confirmation of diagnosis and sputum? That should come later. Here the presentation is cervical lymphadenopathy. So to confirm the diagnosis, your target investigation should be directed towards the neck. We start with ultrasound and then a ultrasound guided FNA.
And then, sir, we'll send culture from the sinus tract also.
That is next. What I'm saying is for confirmation diagnosis, chest X-ray doesn't come here.
Okay, sir.
Okay, it will be to exclude pulmonary tuberculosis afterwards. So to confirm the diagnosis, you confine to the neck. Okay.
So you are basically talking about the ordinary culture, huh?
Yes, sir.
Or is special.
Sir, LJ media, it takes about 6 weeks. So now we can do gene expert, sir, which gives us results in 2 hours.
Gene expert from the discharge.
Yes, yes, sir. Yes, sir.
Then?
Sir, if that is also not confirmatory, then we will go for lymph node excision, means lymph node biopsy.
Lymph node excision. Do you think that that will be possible in this particular case?
8
Excision of the lymph node?
8 centimeter go for excision with the background of tubercular diagnosis.
Sir, so first we will go for anti-gravity drainage of the abscess. And then, sir, if it does not.
What do you mean by the anti-gravity drainage of the abscess?
Sir, we will.
And why is it done? Why is it done?
Sir, because non-dependent drainage helps in better healing. Otherwise, it will again create another another fistula tract. And sir, it is done from the upper border, sir. We will aspirate from the upper side.
You said the swelling is firm in field,
yes,
and
sir.
there is no fluctuation.
Sir, often often we cannot feel the fluctuation also, sir. If it at places where it has not come to the where it is not lying just underlying the superficial fascia, so that time we may not be able to feel the fluctuation.
In other words, I want to know what are the different stages of development of tubercular cervical lymphadenitis. Is there any classification
yes,
regarding
sir.
the clinical situation of a tubercular cervical lymph node?
Yes, sir.
What are the different stages?
Sir, as in stage 1, there is a stage of inflammation, so where periadenitis develops. And
periadenitis in stage 1, no.
Sir,
it is simply an enlargement of the lymph node without any periadenitis, without any. The node fills a discrete firm node, which may even be mobile. So that is the stage 1, simple enlargement of discrete lymph node. So that is the stage 1. And in the second stage, what happens that the infection reaches right up to the periphery of the lymph node, and there is periadenitis, there adhesions develops, and the battered lymph nodes can develop.
Yes.
And next stage 3, what happens?
Abscess formation and caseation of the
abscess formation. So this is the stage where you can get some fluctuations. Actually, most of the patients we do get in this stage 3. So with a central softening of a lymph node. So actually, basically, what are the typical characteristics at this stage of a softened lymph node? That you get a central softening, and what about the periphery?
The periphery is firm, sir.
Periphery is firm with a central softening. That is basically the stage 3. Then what happens?
So then a part of
so this is basically the formation of the cold abscess, okay?
Yes. And sir, from there a part gets attached to the deep fascia, and then it breaches the deep fascia to come and lie to come and lie beneath the superficial fascia. So that actually gives collar stud abscess.
Yes.
And then when it gets adhered to the skin, and then there is sinus formation. Then there is discharge. So following it up with a sinus formation.
One point. Whenever you are having a patient with stage 3, that is central softening with the peripheral rim of firm lymph nodal tissue. Suppose this is the condition. Now, do you think sometimes some other lymph nodes say in the form of a malignant metastatic lymph node that can also be softened.
Sir, it can happen, sir, in the late.
Metastatic lymph node.
Sir, it can happen in the late stage of the diseases when it is secondarily infected with.
Can you specify some situations where the lymph node, a metastatic lymph node, may appear as a softened lymph node?
What happens in metastatic lymph node? Apart from infection, there can be central
Necrosis.
Yes.
Can a metastatic lymph node from a papillary carcinoma appear as a softened lymph node?
Sir,
Yes,
it
can
depends
happen.
on the stage, sir.
It can also happen. A softened metastatic papillary thyroid carcinoma lymph node. Okay, so that can happen. So this should also be considered as a differential diagnosis. Go on. So what happens in stage 5?
Sir, sinus formation, sir.
Sinus
when the
formation
cholesterol
with
abscess
continuum.
get adherent to the skin.
And if an ulcer develops over the neck, what should be the typical clinical feature of a tubercular ulcer?
Sir, it will have irregular margins with indurated edges, and sir, floor will be consisting of
Indurated edges. Indurated edges.
sorry, sir,
Or
undermining
indurated
edges. Sir, undermining edges with surrounding induration.
Surrounding induration with undermine. And what about the discharge?
Sir, floor will have, sir, this creamy white discharge, sir.
Creamy white pus. Typically tubercular pus, what do you want to say? That this is creamy white.
Yes.
You have added the term creamy.
Yes, yes.
So creamy pus, sometimes you can get, do you get sometimes in any acute pyogenic infection? If you say creamy, butter colored pus, thick pus.
Sir, that we can get in, sir, actinomycosis, sir, cervical actinomycosis.
Actinomycosis. Now, what are the characteristic points or clinical points in relation to actinomycosis? Tell me few characteristic points in favor of actinomycosis.
Sir, it is sir, there will be, sir, non-healing.
What are the common sites of development of actinomycosis?
Sir, generally it is the foot, sir.
Foot?
Yes, sir.
Foot?
Yes, sir, foot.
It isn't. It isn't.
Sir, I'm sorry, sir.
Sure. Then now tell me, so if you want to have a detailed etiology classification of lymphadenopathy in the neck, what should be your considerations? Etiology classification. What are the different possibilities? If you say you are having a stage 1 lymph node might be tubercular in the neck, but you have to consider the different possibilities. Okay. So in the stage 1, you don't have any fluctuation, you won't have any discharge. You are simply having an enlarged lymph node in the neck or multiple lymph nodes in the neck. So what can be the other possibilities? Tell me what are the different etiology causes of cervical lymphadenopathy as a whole?
Sir, it can be inflammatory and neoplastic, sir.
It can be inflammatory, neoplastic. Okay. Go on.
And sir, inflammatory can be, sir, acute and chronic. Sir,
yes.
And chronic will list the tuberculosis, sarcoidosis, and acute will
chronic specific infection. Yes, it can be tuberculosis. It can be sarcoidosis.
And acute, sir, it will be, sir, pyogenic.
Chronic. One more important thing. One more important point.
Sir,
HIV infections.
HIV
patients. HIV patients. Do you expect lymphadenopathy in HIV patients as well?
Yes, yes. persistent generalized lymphadenopathy.
Achha. Now, can you tell me some head neck features in an HIV patients other than lymphadenopathy?
Sir, BMI is obviously.
You are considering that this lymph node might be related to HIV. Okay. Suppose a stage 1 tubercular lymph nodes, you are also considering the other possibilities, might be HIV as well. So what can be the other features in the head and neck region in HIV patients other than lymphadenopathy? Intraoral?
The intraoral, there will be non-healing ulcers and
Non-healing ulcers. Candidiasis, you know that candidiasis is very common. So there can be hairy leukoplakia. There can be multiple parotid cysts, parotid swellings with cyst formations. So these are the different HIV related findings. So then what about the neoplastic neck swellings? Just give a class different etiologic causes. Neoplastic.
The neoplastic, again, it can be primary and secondary. So primary, it will be because of Hodgkin's or non-Hodgkin's lymphoma. And secondary can be.
Now some very rare conditions. You are thinking in the line of common diseases, but sometimes it can be related to some rare conditions of lymphadenopathy. Can you name 1 or 2 or 3 such rare conditions where lymphadenopathy can occur?
As in metastasis, sir?
No, metastasis.
Primary.
Very rare causes of lymphadenopathy. Kimura's disease, Castleman's disease, Rosa-Dorfman's disease, something like that. Okay, go on. Now, Dr. Shah. Yes. Hello? Yes, go on with the investigations. Yes, investigations.
Before that, if you say tuberculosis in the lymph node, what do you think is the entry of mycobacteria into the node? How did it reaches the lymph node in the neck?
Sir, it can be due to reactivation of old infection, or it can be a new infection.
How does the infection reaches the lymph node?
Sir, it reaches new infection reaches from the tonsils. The orally, sir, through the oral route from the tonsil.
How does the reaches the lymph node? What is the route of spread?
Sir, route of spread is hematogenous, sir.
Number 1. Anything else?
Sir, and lymphatics also. Lymphatics also.
Focus in the
Sir, I'm sorry, sir. I did not.
Can this bacteria?
Sir, you are getting muted, sir.
And reaches the cervical lymph node direct.
Sir, I did not follow the question.
Go to the pharynx, then via the lymphatics into the cervical lymph nodes. These are the 2 modes of spread to the cervical lymph nodes.
Sir, can you just repeat, sir? Your voice was not audible.
One is hematogenous from the primary focus in the lungs. Second,
hello, there is some audio problem, Dr. Shah. Some audio problem.
Am I audible?
Yes, now you are audible.
Yeah. So this bacteria can reach the lymph node either by hematogenous spread, or second, it can be direct.
Again, some problem with the audio.
Lymph nodes in the neck. Primary affection. These are the ways of spread to the lymph node. You said is always confirm the diagnosis. Discharge may not always reveal mycobacteria.
Yes, yes, sir.
Then
Sir, in this, then we will try, means in this large swelling, sir, we will try and drain the abscess, sir, and observe, and after confirmation and start ATT. So if there is resolution of the abscess, then we have to just wait. And if the resolution doesn't happen, then we have to take the incisional biopsy, sir.
The incision biopsy, why?
Because of such large lymph node, we will not be able
Because
to
you might have some confusion over your clinical diagnosis. That's why.
Sir, not confusion, but to have a confirmed report.
You don't have any confusion, but to have a confirmed report, you are going for an incisional biopsy.
Yes, sir.
Now there might be some confusion as well. It can be some other chronic diseases as well. That's why you should proceed for an incisional biopsy. Now, my one question, possibly this should be your last question, something like that. Now, what is the histopathologic criteria of diagnosing tubercular lymphadenitis? What is the typical histopathologic finding?
The central caseous necrosis will be there, and Langerhans giant cells will be there. And
so, what is the term that we say? That it is basically a granuloma formation.
Granuloma, yes.
Granuloma formation, and it's basically a caseating granuloma. Okay.
Yes.
So, what is the typical histological appearance of a caseating tubercular granuloma?
Sir,
yes, you were telling that.
So central caseating necrosis with Langerhans giant cell.
Yes. Anything else?
And
from center to the periphery,
And sir, there will be granulation.
Centrally it is caseating necrosis. Yes, you will get some Langerhans giant cells. Okay, that is also right. And the other two layers, going from the caseation necrosis to the periphery?
Sir, there will be granulation layer, sir.
There will be some epithelioid cells. And then the last layer should be of lymphocytes and fibroblasts. So basically, these are the three layers of a caseating tubercular granulations. Okay. Dr. Shah, any more question for this short case?
Just one liner. Once you send this specimen to microbiology lab, what else you ask for? Keeping in mind that tuberculosis is the diagnosis. Apart from
sir, we will ask for the drug resistance, sir.
Yes, CBNAT test.
CBNAT, yes, sir.
CBNAT to assess any rifampicin resistance.
Yes, yes, sir.
Okay. What is the standard regime of treatment?
Sir, it is 6 months.
What is the standard regime?
Sir, 6 months course, sir.
Yes.
Sir, and
yes.
category 1 receives the 6 months course.
Associated what is the difference?
Sir, I was not able to follow the question.
Audio problem again. Yes.
A patient has got associated HIV.
Yes, sir.
Will you consider giving the patient intermittent regimen or daily regimen?
So associated HIV, sir, we have to give, we have to give continue with the DOTS as well as the ART, sir, antiretroviral therapy.
Not audible. Yeah.
Sir, we have to go, sir, with along with the DOTS, means along with the ATT, we have to go for ART as well, sir.
Yes. Okay. Dr. Vacha, you can pass on.
Hello.
Because of
second case. Huh? Hello.
Hello.
Hello. Can we have the second case now?
Yes, sir. Yes.
Yes, we can see the slides. Yes. One.
Sir. Good morning, sir. Myself, Dr. Jyoti. I'm going to present the case on lymphoma. Mr. Gentleman, resident of Tolikanchi, who is auto driver, came to the hospital with chief complaint of swelling in both sides of neck for 8 months, fever for 6 months. History of present illness: patient was apparently normal 8 months back, and present illness started as swelling in right upper part of neck, which is insidious in onset.
Go slowly, please. Please go slowly.
Okay, sir. Okay, sir. Patient was apparently normal 8 months back, and present illness started as swelling in right upper part of neck, which is insidious in onset and about 2 centimeters in size. And afterwards, swelling is gradually increasing in size, and patient noticed appearance of multiple swellings on both sides of neck, and from last 3 months, swellings are increasing rapidly. Patient has a history of fever for last 6 months, which is low grade, intermittent. Fever persists for 5 to 7 days, and absence of fever was there for 5 to 7 days, associated with night, sweating at night. History of decreased appetite and significant white loss present. No history of pain or the swelling, cough, hemoptysis, chest pain, breathlessness, change in voice, ear discharge, abdomen. No history of any other swelling. Asthma, hypertension, no history of any prior surgeries. Personal history: takes mixed diet, bowel and bladder habits are normal, no habitual addiction, no history of any tubercular contact, married, 2 children. Family history: no history of similar complaints in the family, treatment history not significant, allergic history not significant. Coming to the summary of the history: 28-year gentleman came to the hospital with swelling in both sides of the neck from 8 months, which started as swelling in right upper part of neck of size 2 centimeters, and afterwards the swelling gradually increased in size, and patient noticed appearance of multiple swellings on both sides of the neck. The swellings were slowly increasing initially, and from last 3 months they are rapidly increasing. History of fever from 6 months, and it persists for 5 to 7 days and will be normal for 5 to 7 days, associated with night sweats. No history of pain or the swelling, associated with decreased uptake and significant weight loss. No other complaints. So, shall I proceed? Sir?
Oh, there is some audio problem.
Sir, shall I proceed? Sir?
Yeah. Yes.
General examination: patient is conscious, cooperative, well-oriented, time-placed person. Kanowski performance status 80, height 156 centimeters, weight 50 kgs, BMI 21.4. No pallor, icterus, sinuses, clubbing, pale edema, generalized lymphadenopathy. Vital signs: pulse rate 90 per minute, regular. Blood pressure 130 of Hg in right upper arm. Respiratory rate 14 per minute, regular. Temperature 98.6 Fahrenheit. Coming to the local examination on inspection: multiple swellings on both sides of neck involving level 2, 3, 4, 5 group of lymph nodes, which are variable sizes of approximately 1 to 3 centimeters in size, and surface appears to be smooth, well-defined margin. Skin of the swellings are normal. Patient: no local rise of temperature, no tenderness noted. Multiple enlarged lymph nodes in both sides of neck involving level 2, 3, 4, 5, which vary in size from 1 to 3 centimeters. Swellings are discrete, smooth, which are rubbery in feel, and surface smooth, which are mobile, which are free from skin and underlying structures. Skin node swellings are normal. Carotid pulsations are normal in portions. Trachea, midline, thyroid gland is normal. Coming to the examination of draining areas: scalp, face, oral cavity, nasal cavity, thyroid are normal. Examination of other lymph nodes: no other group of lymph nodes are palpable. Examination of other systems: cardiovascular system normal, S1, S2 heard, no murmur. Respiratory system normal, vesicular breath sounds heard, no abnormal sounds heard. Gastrointestinal system: no organomegaly, no abdominal distension. Central nervous system: no focal neurological deficit noted. A summary of the case: a 28-year gentleman present with multiple swellings in both sides of the neck, which for last 8 months, which slowly increased in size in right upper part of the neck, progressed slowly, and then patient noticed multiple swellings in both sides of neck. Swellings are increasing in size rapidly from last 3 months. History of fever for 6 months, which are intermittent and associated with night sweats. History of decreased appetite and significant weight loss present. On examination, general survey is normal. On local examination, multiple enlarged lymph nodes in both sides of the neck involving level 2, 3, 4, 5, which vary in size from 1 to 3 centimeters. They are swellings of discrete, rubbery feel and surface smooth, which are mobile and free from skin and other underlying structures. No other palpable lymphadenopathy, and systemic examination is normal. Provisional diagnosis.
Jyoti, bring the audio closer. Audio closer.
Yes, sir. Sir,
Yeah.
provisional diagnosis: 20-year gentleman with bilateral cervical lymphadenopathy, probably due to lymphoma.
Now, in your provisional diagnosis, you have written probably. Is it right to write down probably? In your provisional diagnosis is always provisional. I think you should not write probably.
Okay, sir.
Because you might be wrong in your provisional diagnosis. That is to be investigated. But you should not write probably.
Yes.
Now, in your clinical examination, you have stated that the feel of the lymph node is rubbery. What do you mean by the rubbery feel?
Sir, which is a soft in consistent associated with some gritty sensation.
Is it rubbery feel?
It's soft.
Now, 3 basic feels of a lymph node is either it is soft, or it is firm, or it is hard. Basically, where would you put this rubbery feel? Between soft and firm, or firm and hard, or it is beyond hard? What is this rubbery feel?
So firm in between.
In between?
Firm and hard, sir.
Yes, in between firm and hard. Okay. And then, so I would like to ask you, what are the different areas of the body you have examined in this particular case?
Sir, I have examined the axillary group of.
Go slowly. What are the different areas? What, sir? You have. So firstly, the locoregional. What are the different areas you have examined? Locoregional.
Yes, sir. I examined axilla.
Axilla.
And,
yes.
And I examined mediastinum, sir.
Mediastinum you have examined clinically? No?
So clinically, I just
no, during your clinical examination, what are the different areas of the body you have searched or you have looked?
You cannot assess mediastinum. Jyoti, you cannot feel mediastinal lymph nodes. What are the sites where other lymph nodes are to be palpated?
Sir, axilla, groin group of lymph nodes.
Yes.
Epitrochlear group of lymph nodes.
Achha. Okay. Okay. So other
what in abdomen? What in abdomen is important?
Parietal group of lymph nodes.
Apart from that, anything else in the abdomen is important for patient having lymphoma?
So pelvic retroperitoneum also we have to.
These are lymph nodes. Anything else in the abdomen? Any organomegaly?
Extranodal. Yes.
Hepatospleen.
Yes.
Spleen and liver.
Yes.
Also. And then in the head neck, what are the other areas you have examined? Because that should be a comprehensive clinical examination.
Yes, sir. Sir, I have examined scalp, face,
scalp, face, yes.
It's a nasal cavity.
Nasal cavity, okay.
Oral cavity, tonsillar area.
Oral cavity, tonsillar area.
Yes, sir.
Not the external ear or the mastoid region, not the external ear as well. Not the thyroid gland.
And salivary glands also are examined. So thyroid gland.
Salivary glands, thyroid glands. And the posterior aspect of the tongue. So the age is only 20, na? You have mentioned. What is the age of the patient?
20 years.
20. And then what are the points in favor?
How do you justify the diagnosis?
Yes, that is the case.
Yes. Justify provisional diagnosis.
So from history point of view, patient age and the patient, his symptoms like multiple swellings on both sides of the neck and the type of fever, which is present for 5 to 7 days and absent for again 5 to 7 days, associated with night sweating and presence of weight loss, significant weight loss. On an examination point of view, sir, there are multiple group of lymph nodes which are discrete and rubbery.
The symptoms of fever, night sweat, and weight loss is common for lymphoma and tuberculosis.
Yes.
Okay. So, if it is lymphoma, how do you take these symptoms as?
Sir, B
These are
type of.
indicate B symptoms in lymphoma. Okay.
Yes.
Can you mention another one important symptom
Sir,
included as B symptoms?
Sir, pain.
Fever, night sweats, lethargy, yes, fatigue, all these things. Apart from these things, another one important B symptom, that is pruritus.
Pruritus and pain.
Pain. Okay.
So you have a strong provisional diagnosis of lymphoma. How are you going to confirm the diagnosis? You have a strong suspicion of lymphoma, not tuberculosis in this patient. What should be your next step for confirming the diagnosis?
Sir, after doing the ultrasound of the neck, I will go with the excisional biopsy of the swelling.
Yes, don't say FNA. If you have a strong suspicion of lymphoma, FNA is not helpful. If you have a diagnosis of tuberculosis, yes, FNA should be the answer. Otherwise, you do the ultrasonography. But even if you have such large lymph nodes throughout the both sides of the neck, even ultrasound may not add more except finding the thyroid. Okay, so you should be why excisional biopsy? Why not a FNA in lymphoma?
Sir, we want to know the histology of the specimens. In FNA, we will get only cytology. To know the
FNA gives only lymphocytes, does not give a diagnosis of lymphoma, and you need to typify the lymphoma. The lymphoma needs to be typed based on the histological features. What is the classical histology of a Hodgkin lymphoma? What do you find?
Sir, Reed's universal is the classical features.
Yes.
To identify
Reed's cell. And apart from this, what do you find in the background?
Background of lymphocytes and eosinophils and histiocytes.
Mainly lymphocytes. Okay, you have a diagnosis of lymphoma, Hodgkin lymphoma in this patient. Yes. What next?
Sir, I want to go with the staging investigation.
What?
Sir, I want to go with the staging investigation. So with the chest X-ray, ultrasound, abdomen. If I'm having any suspicion, I will go with the CT thorax and CT.
Don't go with the chest X-ray and ultrasound abdomen. That is not the guideline for lymphoma staging.
Yes.
So CT thorax and CT abdomen.
Yes. CT thorax, CT abdomen and pelvis. And another important investigation now is a part of lymphoma care. Everyone does this because that is a baseline assessment for systemic disease.
So PET.
Yes. PET.
Yes. Go on.
PET scan.
It is.
Yes.
PET CT. FDG
PET CT is now standard of care. It's a standard of care for lymphoma. One is baseline PET CT, even if you don't have the distant disease, and then you need to repeat the PET CT in between different cycles. Okay, so PET CT. So don't say ultrasound abdomen. That is not the basic investigation for staging of the disease. We can do ultrasound as part of extension clinical examination, but for staging of the disease, CT thorax, CT abdomen pelvis, and a PET CT. Okay, so
yes.
why is PET CT important?
So to know the systemic spread, also bone involvement, bone marrow involvement, and
any role for bone marrow biopsy?
So bone marrow biopsy, if a patient is having a high advanced disease, then we can go.
No. If this patient has two lymph node site being involved.
Yes.
This patient has two lymph node site being involved. So for proper staging, bone marrow biopsy is one of the important investigation. But if you are doing a PET CT, then bone marrow biopsy may be omitted. Understand? If you are doing a PET CT scan, then bone marrow biopsy omitted. Otherwise, bone marrow biopsy is part of staging investigation, because bone marrow is positive, it become a stage 4 disease.
Yes.
Okay.
Diffuse involvement. Hello.
Hello, sir.
How do you stage these patients? How are the patient lymphoma are being staged?
Sir, by Cotswold magnification of Ann Arbor staging system.
What is that?
Sir, it is stage 1 is involvement of a lymph node group and one group of lymph nodes or one extra lymphatic site. Stage 2 is involvement of 2 or more group of lymph nodes on same side of diaphragm. And stage 3 is involvement of 2 or more group of lymph nodes on either side of diaphragm. And stage 4 is disseminated.
Yeah.
And again, it is staged as A and B. A is absence asymptomatic and B is symptom with fever, night sweat, and weight loss.
No. These are B symptoms, not stage 1A and B. 1A and B are the favorable disease and unfavorable disease based on number of other factors, not the B symptoms. B symptoms are part of unfavorable histology, unfavorable disease. Okay, other factors also taken: age of the patient, disease is bulky or not, ESR. Okay. Okay, so once this patient has got involvement 2 lymph node sites, where do you place the patient? The other investigation are showing no distant disease. What is the staging in this patient?
So stage 2.
Stage 2. And if the patient has got B symptoms, where do you place this patient? In favorable group or unfavorable group?
Unfavorable groups.
Unfavorable. So now you have to plan the treatment. Once you have diagnosed this patient as a Hodgkin lymphoma, classical Hodgkin lymphoma, and other diagnosis may be non-Hodgkin lymphoma.
Non-Hodgkin's lymphoma.
How do you differentiate between Hodgkin and non-Hodgkin lymphoma?
Sir, age group. It's non-Hodgkin's lymphoma usually in elderly age group, and involvement of extra lymph node is more common in the non-Hodgkin's group of lymph nodes.
And then histologically,
it will be absent in the non-Hodgkin's type of lymphomas.
There will be no RS cells in non-Hodgkin lymphoma. Okay, so prognostically, which is a better?
Better.
Sir, Hodgkin's lymphoma will be the better prognosis compared to non-Hodgkin's lymphoma.
So, what treatment will you offer for this patient? Having 2 lymph node sites being involved, what treatment will you offer for this patient?
Sir, as it is stage 2, I will go with the radiotherapy, external mantle radiotherapy.
Stage 2 lymph node site involvement, the primary treatment is radiotherapy. Are you sure? What is the preferred treatment?
Sir, early stage.
You see, the preferred treatment is chemotherapy, because you have 2 lymph node sites being involved. So 1 lymph node site involved, primary radiotherapy can be considered, but 2 lymph node sites on either side of the neck, the primary treatment should be a standard chemotherapy. Okay. So what chemotherapy is the standard of care for Hodgkin lymphoma?
Sir, ABVD, adriamycin, bleomycin, vinblastine, and dacarbazine.
Okay. How do you assess response to treatment?
Sir, patient symptomatically improving and the size of the lymph nodes are decreasing, and we can assess with the PET scan to assess the response to chemotherapy.
You see, there is a scoring. That is the standard of care. After giving 2 to 4 cycles of chemotherapy, you would repeat PET CT scan. And what is the score they use to assess response based on PET CT finding?
Sir?
What is the score being used? What is the score being used to assess response to treatment on PET CT scan? This is Diouville score. This is Diouville score. Depending on the uptake of the PET. Okay. So if it is no uptake, it is 0. Then one is mild uptake. Two is uptake which is equivalent to the uptake in the liver. Three is more uptake. And four is market uptake. So that is how you assess the response to treatment. Suppose you have given this patient 6 cycles of chemotherapy, and then you find that disease is persisting. What should be the next course of action?
So we can go for.
Yeah.
Sir?
After 4 to 6 cycles of chemotherapy, repeat PET-CT showed the disease is persisting.
So if disease is still persisting, we can go for radiotherapy.
Yes, that is the situation where you have a persistent disease. What is that type of radiotherapy called as?
Extended mantle radiotherapy.
There are two terms being used. One is ISRT and IFRT.
Yes, sir.
What is that two?
Involved focal radiotherapy, involved site radiotherapy.
One is involved site radiotherapy
Involved field.
and involved field
field.
radiotherapy. Involved field radiotherapy gives radiation to the larger area. Okay. So if we give another scenario, that patient on investigation has revealed that patient has got disease in the bone marrow. So where the patient goes now?
Sir, it goes into the advanced stage 4. Sir.
Stage 4. What is the treatment regimen for stage 4 Hodgkin lymphoma?
Combination chemotherapy, sir, with
Chemotherapy.
combination chemotherapy. Yes.
Same regime, ABVD.
Yes.
Then
Sir?
how do you progress? You start the patient ABVD. At what point of time you reassess the patient?
Sir.
After 2 to 4 cycles. After 2 to 4 cycles, you have to repeat the PET-CT scan. Okay.
Yes.
Suppose on repeat PET-CT, there has not been marked response to this treatment. What should be the next line of action? Repeat PET-CT does not show marked reduction in the disease process.
Don't know, sir.
Next, you have to go for the second line chemotherapy, which is described as a Stanford 5 regime, where they use 6 drugs. The combination of 6 drugs for Stanford 5 regime, or there is another regime called as BECOP regime, BEACOPP. Okay, neomycin, etoposide, vincristine, cyclophosphamide, then procarbazine and prednisolone. So this is these are the second line chemotherapy. Okay, suppose even with the second line chemotherapy, patient is showing refractory disease. What do you mean by refractory disease?
Not responding to the chemotherapy.
So what should be the next line of treatment? Patient having refractory disease, even with the second line chemotherapy.
Radiotherapy.
No, systemic disease. Radiotherapy is not helpful. Any role for immunotherapy?
Yes. Sir, rituximab or trastuzumab can be.
Any role for immunotherapy? Nivolumab, pembrolizumab. So the other immunotherapy which has been advised for advanced disease. Any other modality of treatment apart from immunotherapy? This is being done for lymphoma patient, for advanced lymphoma patient. These are now standard of care.
Bone
Have you
marrow.
heard of stem cell transplantation? Stem cell transplantation. Am I audible?
Yes, you are audible.
Yeah. Any role for stem cell transplantation? Yes. If the patient has got a refractory disease and patient is not receiving second line of chemotherapy, one can consider for giving this patient either autologous stem cell transplantation or allogenic stem cell transplantation. So how is this done? Patient is given high dose chemotherapy so that you kill all the normal bone marrow cells and then administer the patient either pre-collected his own stem cells or collect from a living donor, a allogenic stem cell transplantation. These will create new bone marrow cells and patient can be cured of a systemic disease of lymphoma. Okay, so one should read. You see, lymphoma treatment has changed a lot. So you should read at least first line chemotherapy, second line chemotherapy, some points on immunotherapy and stem cell transplantation. So these are the different modalities of treatment. This patient has responded to your treatment. How do you follow this patient up?
So first, in first year for every 2 months, and for next second year for every 3 months, and for third year every 4 months, and 5 year for every 6 months, sir. And clinical examination, history examination, and if necessary, investigation.
Some investigation has to be done in each follow-up visit. Only history examination may not be always corroborative of relapse. Some investigation has to be done, like
So ultrasound.
Physical examination. Apart from that, you have to do blood biochemistry. Okay, serum LDH level, serum macroglobulin level, ESR. Okay, and if the symptom is suggestive of something, you have to do approved investigation in the form of CT chest, CT neck,
Abdomen.
or CT abdomen pelvis, depending on the patient symptom and other corroborative findings. Okay, because what is the idea of follow-up in these patients?
So
Why do you follow-up in patient has got lymphoma treatment?
So recurrence will occur in the first 2 years of treatment.
Let us understand. There are important points. One is to detect the relapse, number one. Number two, to detect toxicities of the treatment which has already been offered. Given radiation, this patient can develop thyroid malignancy. This patient can develop breast malignancy if you have radiated the mediastinum. The other patient can develop toxicities to the chemotherapeutic drugs. And next is the other patient who can develop a second malignancy. So the idea of follow-up is to detect relapse. Number two, detect treatment-related toxicities. And number three, to detect any new malignancy coming up. So keeping in mind this, we should always do that follow-up clinical examination and relief investigations. This patient may become hypothyroid in the follow-up. Why?
Sir, because of radiation to the thigh.
Yes, if you have been radiation to the neck, the patient may become hypothyroid. So a TSH examination, the follow-up is also a part of care. Okay. Dr. Bhattacharya, any other question?
So we are already 9. I will ask you just 1 or 2 questions coming on to the clinical side again.
Yes,
Now,
sir.
suppose you are thinking in the line of lymphoma, okay? But, but if you go for a cytological examination and if it comes to be a metastatic carcinoma of thyroid gland, it can be, it can occur. Accidentally, it has come to be a metastatic carcinoma, metastatic papillary carcinoma of the thyroid gland without any visible thyroid swelling. So what is this metastatic situation commonly known as?
Sir?
What is this? Thyroid swelling is not clinically visible, but you
Lateral
can find
swelling
this
with
metastatic lymph nodes.
Thyroid carcinoma, known as what?
Lateral aberrant.
Lateral?
Aberrant
Lateral
thyroid.
aberrant thyroid.
Lateral aberrant thyroid. Now, what can be done in this particular situation? If it comes to be a case of metastatic papillary carcinoma of the thyroid gland, just one or two lines.
What is the treatment malignancy which is occurring?
Sir?
So, if you accidentally discover that these are the metastatic lymph nodes of a papillary carcinoma of the thyroid gland,
Yes.
but no distinct swelling in the thyroid gland can be discovered, what would you do?
Sir, I can, if it is operable, we can go for modifier.
Yes, go on. Yes.
Sir, if it is operable, we can go for a neck dissection. If it is
So would you go for a total thyroidectomy? This is first thing.
yes, sir.
Yes,
Only-
you have to
only
go for a
not with
total
the-
thyroid because it can be an occult carcinoma in the thyroid gland.
Yes, sir.
So total thyroidectomy plus treatment for the lymph nodes. And what treatment for the lymph nodes?
Sir, neck dissection, or it can be modified
Yes,
radical neck
it can.
dissection, or
Yes.
It can be a modified radical neck dissection. Okay. And the last point, histological thing regarding lymphoma. If it is an Hodgkin's lymphoma, how is it classified histologically?
sir, histologically it can be nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted.
Yes.
Where is the
first-
prognosis best and where is the prognosis worst? Last question.
So prognosis is very good for a nodular predominant type of Hodgkin's lymphoma, and worst for a lymphocyte depleted.
Okay. Thank you. Thank you.
Okay.
Dr. Shah,
Thank you.
please.
Yes. Thank you, Dr. Bhattacharya. We have covered. What I'm trying to say is, you should always keep in mind a list of differential diagnosis. Number two, don't give a wild second diagnosis. The diagnosis should be coming closer to the clinical presentation, and then confirm the diagnosis by real investigations, and then treatment based on the staging of the disease. And you should be always knowing the other options. You see, there are a lot of options. There are a lot of clinical trials in patient having lymphomas. Okay, so you should be answering the standard treatment which is being offered to the patient based on the stages. Okay, thank you, Jyoti. You presented well. Dr. Bhattacharya, thank you. Thank you.
Welcome.
Okay.
Thank you, sir.
Yeah.